al programa, vamos a tener en este momento a un ponente que se encuentra en Italia, el doctor Filippo Cademartiri, y para presentarlo invito al doctor Erasmo de la Peña Almaguer, quien es médico cardiólogo egresado de la Universidad Autónoma de... ¿De dónde es, doc? De Coahuila. UADC me puso aquí. Instituto Nacional de Cardiología, posgrado en imagenología cardiovascular avanzada en la Universidad de Harvard y Universidad de Stanford, y quien estará acá presentando al doctor Filippo Cademartiri. Adelante, doctor, por favor. Muchas gracias. Un aplauso para el doctor.
Muchas gracias, buenas tardes a todos. Estas son de las pláticas que yo les diría que grabaran para que se las enseñen a sus hijos o a sus nietos, porque lo que estamos a punto de ver es un cambio en el paradigma de la forma de hacer las cosas. Y la manera en la que yo lo veo, esto es como cuando se inventó el teléfono celular y cuando tuvimos el iPhone. La historia lo ha dicho. El doctor Filippo Cademartiri es además de ser un brillante médico y una persona que tiene un pensamiento que está muy por delante de lo que se vive y lo que se necesita en estos momentos de mucho desarrollo tecnológico. Él es radiólogo con especialidad en imagenología cardiovascular. Él es de Parma originalmente en Italia y estudió de igual forma en la Universidad de Parma y posteriormente realizó su entrenamiento en imagenología en la Universidad de Erasmus, mi tocayo, en donde trabajó y actualmente ocupa también un papel entre Pisa como encargado de la parte de imagenología cardiovascular de el monasterio de Treviso, que es una especie de sistema de investigación del gobierno italiano, en donde hay muchísima investigación. El doctor, de igual forma, ha sido una persona que ha publicado muchísimos artículos, es una persona que nos está enseñando la luz en esta nueva metodología. El doctor Filippo nos hablará acerca de la tomografía de conteo de fotones, que es una forma diferente en la adquisición de las imágenes a la que estamos acostumbrados, en donde se adquiere por energía. Ciao Filippo, ¿cómo estás? We can't hear you. No. Sorry, we can't hear you. Let me. ¿Tenemos audio? Sí.
Can you hear me now?
No, we can hear you. So, thank you for joining us. So, it's a pleasure to see you again. Please go ahead and let us know what the future looks like.
Thank you very much, Erasmo. It's an honor to be able to give this presentation to you and to all your team and to all the people over there. Maybe next time I will manage somehow to be there in person, and we will talk again about this topic. So the topic of today is photon counting CT. Photon counting CT, now we have 2 years of very intensive experience, and we had most of this experience on cardiac and cardiovascular CT. It's not a cardiovascular machine. It can do everything, but today we will focus, of course, just on the cardiac aspect, the cardiac impact of photon counting. Photon counting looks like a CT. It's a little bit bigger as compared to the biggest CTs. In this case, it has 2 detectors and 2 tubes, but this detector is really the core of the machine. The machine has a new kind of detector. It's not just a better detector, but it is a new kind. I will not go into too many technical aspects because I want to show you as many images as possible in order to give you the chance to understand how big is the difference. I will just say that in the new age of atherosclerosis, in which, in order to personalize advanced therapies, we need a direct phenotyping of atherosclerosis, like we all know. This is the tool that will open this gate and will allow us really to perform almost histopathological imaging in every patient we treat. So technological advancement are very important, but I will start just with the two main concepts: state-of-the-art CT scanners. So we are not talking about photon counting, just the best of the best scanner before photon counting, temporal and spatial resolution. These are two key components. Then we will see a third one, but we can discuss it when we go into photon counting. Temporal and spatial resolution. This is the highest temporal resolution you can get on a CT scanner. This is a myocardial bridge on the proximal LAD. You can see it also here, and you can see it also in the axial phase. There is a little bit of milking at rest. So this is possible because you have enough spatial resolution and also, but even more, temporal resolution. So you can resolve most of the phases of the cardiac cycle because of this. This is just enlarged. You see here in the proximal LAD, the systolic compression. But also spatial resolution. And this is the best you can get with a non-photon counting CT scanner. This is a stent. There is intimal hyperplasia here, and you can see it here. When you are used to these images, for you, it's, let's say, quite normal to have the capability to detect this kind of intimal hyperplasia. Here we are in the range of 200 to 250 microns resolution, but it's not just about the absolute value of resolution, and we will see it. So this is the best we had just before photon counting. Then we switch to photon counting. What happens? It happens that the detector is different. It is made different material, different performance, and also the capability to count the photons, X-ray photons coming in, and also to allocate the energy range of each photon. So instead of getting a full peak of the signal in every detector, we can actually count the detectors. The detector is much smaller. Instead, we can plot the different energies of the incoming photons. This is another way to look at it. So you see the ratio of the size of the detector is very evident. How big is the difference is really much larger for conventional detector as compared to the elements of the semiconductor of the photon counting detector. And because you can count and you can define the actual range of energy of each photon, you can also filter the noise. And you can have much, much less noise, which allows you to have much better images, much higher resolution, and also less noise, which means you can work with a lower radiation dose. So stop with technique. This is day one with photon counting, and it was the CatFan Phantom. This is how you test the performance of the scanner when you install it. And normally, you don't see this part because the resolution you must have to get to this part is too high. You don't reach that. But now we get here. We never got here. And this is the image that demonstrates that the actual resolution is 0.1 millimeters, so 100 microns. 100 microns is the spatial resolution of the scanner. This is a patient who underwent CT with a proximal LAD stent in 2013, 2016, and 2024. And this is a standard 320 slices. This is 128 slices, and this is the alpha. When I say alpha, I mean the photon counting. It's called neotom alpha. And you can see on these images that we go from these images to this image to this image. So it's a complete change. Of course, there is a change also in temporal resolution, but the main change is the spatial resolution, the fact that metal structures like stents are not affecting our capability. And this is a standard patient on a photon counting, but with the reconstruction parameters of, let's say, 10, 15 years ago, of 5 to 10 years ago, and this is with the alpha parameters, so the 100 microns, and you see the difference in spatial resolution. Temporal resolution didn't change with this scanner. This is how it would look a normal coronary tree when we look at it using standard parameters on an alpha. You see the images are already, there is much less noise, but when you switch to the high resolution, this is what you get. So the borders, the boundaries of everything, they are much improved. So let's go and dive a little bit into coronary artery disease using photon counting. This is a normal LAD, but you see how many pixels there are in the vessel lumen. Normally, you have few pixels to represent the entire lumen, but in this case, you have actually a good image. You don't see the pixels because the resolution is good enough to have the possibility to define very well the borders. And this is a proximal LAD. I will use this kind of examples because I think to focus on segments of the coronaries give you a better idea of what we can see and how close we are to intravascular imaging. Actually, we are superior to intravascular imaging for many, many cases, not all cases. Of course, the fibrous cap or the necrotic core is not something that you see every day, but for the rest, we are much better. And this is a normal coronary with a slight thickening, just a slight thickening over here of the wall that is absolutely not possible to address with any other technique unless it is an invasive one. This is a case in which the coronaries were normal. The calcium score was 0 in every way. It was always 0. But because we use high resolution, this patient can show us a slight thickening of the wall and also a very, very microscopic calcification, which is now visible, and the size of this calcification is more or less in the range of the 100 microns. So patients that we would classify as completely normal, they are not normal anymore. They become early diseases. Already they enter in the phase of early stages of atherosclerosis. And then we get to more disease. You see how calcifications are absolutely not impacting the lumen and how easy it is to detect the calcium, the non-calcified plaque in the middle, again calcium, and again another calcification over here. Look at the thickening over here. But the lumen is absolutely unaffected. There is absolutely no difficulty in addressing the fact that the lumen is not impacted by any artifact, by any blooming of the calcium. Another type of plaque, this is a proximal LA, this is a left main actually, and this is a much larger plaque. There is a linear calcification. You see the calcifications, they are always on the outer border of the vessel, and there is a slight component with it's over here, if you can see it, it's non-calcific plaque. Let's go a little bit into calcium because calcium is the first thing that strikes you really hard when you start using this machine. This calcification is very thick, is very big, is very bulky, but it doesn't affect in any way the lumen. And this is what normally happens with calcifications. It's very rare that the calcification is affecting the lumen, but on CT, calcifications were usually a problem when they were too big or too extensive, because it was not possible to really have a complete and sharp visualization of the lumen. So in this case, there is absolutely no problem. You see all the different longitudinal visualization. This is a CPR stretched, and this is a stretched MIP. Another very bulky calcification over here that is much thicker than the one that we just saw. And anyway, it doesn't really show anything. Another interesting part of the image is that you see the calcium and you also see the non-calcified tissue just below, just under the calcium. That could have been called as an artifact in the past, but now we know it's not an artifact. That is a non-calcified component within the calcification that stays on the side of the lumen. And to show you the example that sometimes it's very rare, but it happens, like in iliac arteries, for instance, that there is a calcification that is very bulky and is going into the lumen. And this is not blooming, this is the actual calcification. And this is the stenosis. There is a stenosis. You can measure the actual stenosis, and there is a corresponding image over here. So you have the possibility to go and dive into the coronary even when they are really, really calcified, and there is no problem. This is another pattern that we are studying right now that is very interesting that we never saw before. It's a kind of shell-like or donut-like shape of the calcification. So there is a shell around the necrotic core of this plaque. There is calcium below, close to the lumen, and also on the outer border. So this is another phenotype that we couldn't explore. And also, no intravascular invasive technique can explore this phenotype. Nobody saw this before. This is new. And you will remember about it because we are writing something very nice about it. Another very nice image that I like very much because it shows you that there is no one type of atherosclerosis or plaque in one segment of the coronary. This is a middle LAD, and you see that this entire plaque is eccentric and it has a kind of half of it or two-thirds of it are completely calcified, and it's here. But there is another part, the distal edge of this plaque, that is completely non-calcified. It's eccentric, it's low density. So the risk is not in the average type of plaque that you see on the images, but is in the parts of the plaque that you can isolate from each other, and you can distinguish that right now with this technology in a very easy way. It's not that difficult. This is a more conventional uh, type of atherosclerosis with plain calcium over here, no impact on the lumen. You see it here, and also a mixed plaque. And you start to see also another time these two different patterns of calcification, one on the edge of the lumen and the other one on the outer border. So these are all different things. We we never had a chance to clearly see these kind of things. Now we shift a little bit into non-calcific plaques. This is calcified, of course, as you can see here, but more distally on the LAD, you see this very irregular profile, and below that, there is this kind of wall thickening that is completely non-calcified. And you see something that also was very difficult to see before. While this part of the plaque with the positive remodeling is very easy to see, you can also see the thickening on the other side. So it is possible to see the thickening in the non-eccentric part of the plaque on the other side of the eccentric part of the higher focal burden of atherosclerosis. This is a similar example, again, proximal LAD, non-calcific, very easy, very sharp border. You can see how sharp it is to define exactly and also to measure how exactly is the stenosis. Another example, I think this is probably one of the best example of plaque biology that I have in my database. You can see this plaque of the proximal right coronary is completely non-calcified, but it is enhanced. This plaque is enhancing. You can see here the density inside the plaque is higher, and this is because it's inflamed, it's more vascularized, and we are going into this kind of topics right now, especially because we can do spectral imaging on the arterial phase and in the protocol with a high resolution. And I will show you something at the end of my presentation. So we can go further and we can see different type of mixed atherosclerosis. This is a very big patient. You see, there is a lot of noise in these images. These images to the non-trained eye, they will look very noisy, but they are actually showing you a much deeper level of information because while you have noise, you also have, because of the very high resolution, much more information. And to study the lumen is very easy, but also to study the arterial wall is also very easy. Again, this is just wall thickening on the right coronary artery. You see here, and also here, slight wall thickening with very few calcifications. And this is a completely another field. If you go to pathology books, you will read that the normal thickness of a proximal coronary artery is in the range of 80 to 110 microns, which means that when we see a thickening with this kind of technology, that is already atherosclerosis. So we have a tool which is set at the level of increased thickening of the arterial wall. Again, another calcification. You see very sharp, no impact on the lumen, absolutely no problem. Another time, very large plaque, it's positive remodeling, and there is calcium on one side and on the other side. So you can start splitting many different phenotypes of calcification. This is a much more diffusely diseased proximal coronary artery. There is a stenosis, dilatation, stenosis, and again, normal lumen, and mostly non-calcific and very easy to define the entire plaque, non-calcified plaque tissue. This is also another example of this non-homogeneous phenotyping of segmental atherosclerosis. In the same segment, you have calcium, non-calcified plaque, calcium, non-calcified plaque, and calcium again. And depending on where you put your point of observation, here or just below, here or just below, here, you see three different types of plaque. One is very high risk, this one on the left. This one is middle range, and this is very low risk because this is almost concentric calcification, but absolutely no impact on the lumen. So we need to recreate a library of what we think is high risk, low risk, and how to evaluate all of these things as a whole in the patient. This is an example that I animated just to show you a non-critical stenosis and how sharp and very easy is to really define the edges, the borders of the stenosis and provide minimal lumen area as you would do with the IVUS. So absolutely no problem. I I have to say that mostly FFRCT for me does make sense anymore also because of this reason, because what is the point if I can measure so accurately the morphology? And most of the literature shows that if you measure IVUS and you perform FFRCT on the same vessel, you get mostly similar results. And now we go a little bit, we dive a little bit deeper. This is a normal stenosis. Well, this is not very difficult to assess. It's a high grade uh, middle LID stenosis. But what I want you to notice on this image is this particular pattern. You see high density calcification, nothing in the lumen here. low density calcification, this huge non-calcified swelling almost part of the wall. So the density of the calcium within the plaque is also an indicator of the activity, of the metabolic activity, of the inflammatory activity of the plaque in itself. When the plaque is active, the calcification is lower density. When it's stable, it's going to be high density. This is the same patient. It's basically 99% occlusion over here. On the CT, actually, it looks like it might have some contrast going through, but it's really thin over there. Occlusion of the middle LAD, you can see here something that we also never saw before, which is, of course, the different densities very clearly between the part that is the stump of the occlusion and the part that is more distal, which is more fibrotic, most likely. Well, this is more like to be a thrombus or lower density. Uh, and this is also an information that is useful in order to understand what kind of resistance I might find when I put a catheter into that lesion. And then we go to my preferred topic, probably, is stents. I've been working on stents since the beginning of CT, so it's more than 20 years. This is one of the first stents we scanned. It's multiple stents in the proximal right coronary artery. These are all different visualization. It's all the same stent. You see the struts of the stent, the one stent, another stent. When one starts, the other, the overlapping. So, and you see even better here the overlapping area of the two stents. It's wonderful. It's just like there is no actual artifact inside the stents. This is a much smaller stent in the circumflex. Again, you see the stent struts and you see the lumen. And this is okay. This is a distal right coronary stent, and this is a circumflex stent. So now we will go to many stents. This is a proximal LAD, very easy. And you see how it doesn't really affect. It's like calcium. It's not really affecting the lumen, your capability of saying what's exactly inside this stent. Can I see it? Can I really name it? Can I tell if there is something or not? And you will see it even better when we will see what a instant restenosis looks like. This is another stent, very well positioned. I must say this is really a good procedure because it looks like it's crafted really on purpose for this patient. And now we go into a situation that is also very. You can have stent, of course, but you can also have calcifications around the stent. So there is a plaque and there are calcifications, and then you have a stent and the calcifications around. And this is the reason why many times we have very heavy beam hardening artifact. But here you see the calcifications. They are a bit less dense as compared to the stent over here and over here. But they don't affect your capability of looking inside the stent. Again, calcification, calcification, calcification. They are here, 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 but the stent doesn't really suffer in the visualization inside the stent. Again, another stent, big calcification in the proximal part that is here and here, no problem inside the stent. Another example, calcifications over here, the stent struts, the lumen of the stent is absolutely unaffected. Here you see all the calcium that is running in the vessel and around the stent over here in the MIP visualization. This is another very complex situation because there are several stents in different vessels with different sizes, and the small ones are very small. These are the smallest you can basically put because these are 1.8, so it's very small. This is the biggest one. Of course, it's fine, even though there is a lot of disease just above the stent. This happens when you put stents sometimes and you don't perform coronary wall imaging, so you don't cover completely or properly the proximal disease. And you see it very clearly at this level. There is a non-calcific plaque here, while the calcium is outside, but it could have been a longer stent. And this is the circumflex, and this is the marginal branch. Very small stents, no problem at all. Same example. This is another example of a very, very small stent. Don't ask me why is such a small right coronary needed a stent, but it was there. And again, it's an 18 millimeter stent, and it's fine. This is the smallest stent, and this patient was also big. You see, it's a very noisy image, but still very easy to assess. Again, the proximal disease of the stent, but you can clearly see that it's mostly positive remodeling, doesn't affect really the stenosis in the lumen. This is the coronary angiogram of this patient. You clearly see that is completely different perception of the two things. So you look at this and you look at this. Here you see irregularities. Here you perfectly understand where is the non-scary disease and where is the scary disease. You don't have any problem in understanding. Also in a spider view, again, in the same patient. Okay, we have some examples here, like in this case of intimal hyperplasia. And now you start seeing how we see intimal hyperplasia. This is the perfect image. It's like an IVUS. The border, the edge of the intimal hyperplasia as compared to the lumen is very easy to understand and to measure also if you want to see a stenosis. Another example, you see concentric or slightly eccentric intimal hyperplasia, still not critical, but very easy to depict, very sharp, very consistent. And again, very huge calcification outside the stent over here, no problem looking into the stent. Again, over here and over here. Another example, similar, bulky, very huge calcification, no problem looking into the stent. These are the worst situations that you can find yourself in when you do CT. So having stents, small stents is worse, and calcification at the same time. Here another example, big calcification, no impact in the lumen, okay? And this is a more recent example that I prepared, because you see there are several stents, 1, 2, 3, 4 over here, and this is the axial image showing that there is absolutely no problem in the visualization of 4 stents at the crux, all together in small distal branches. This is another example that I like very much, because also stenting bifurcations can be difficult because more metal can overlap. In this case, there is no problem. It's very easy to depict the lumen, even when there are multiple struts at the same level. Now, I will go a little bit into the spectral capabilities. I told you before at the beginning it was temporal resolution and spatial resolution. And then now we go into contrast resolution. Contrast resolution exists also in standard scanners. But the problem is that as compared to an MRI, especially, CT has a lower contrast resolution, even though it's a technique in which absolute values are more reliable. So we can give number to a density, electronic density. So in a way, it's better, but in general, we can say it is worse. With photon counting, we start doing spectral as a routine tool. Every patient can get a spectral, and this is a first take on it, like 40 keV image, 65 keV image. So we shift the image. The acquisition is the same, but we can change how we visualize the interaction between the X-ray beam and the actual matter. In this case, it's iodine and the tissue of the body. And in fact, one of the way to visualize is the iodine image, in which we see mostly the distribution of iodine and also the late phase, in which there is a slight delayed enhancement here on the lateral wall. Now we will see some examples. And this is the iodine map. This is the late phase with the overlay of color-coded map. And you see that there is a higher density over here, which corresponds exactly to late gadolinium enhancement, as you can see here. Of course, for CT is even with these capabilities is more difficult to get good images for late gadolinium enhancement. Why? Because late gadolinium enhancement is an artifact. You know what you call normal myocardium in order to see what is enhancing. While in CT, we don't have any knowing of any part of the myocardium. We always have the enhancement that is the contrast that is distributing, going in, staying, and then coming out of the tissues. So it's more difficult. We need uh, proper protocols that we optimized and also proper tools to eventually visualize it better, but it is exactly the same, basically. This is an example of a patient post-infarction with the thrombus and also delayed enhancement of the infarcted wall with different layers. You see here there are two layers. There is microvascular obstruction, most likely in the distal part. This is the arterial phase, and this is the venous phase. This is a hypertrophic cardiomyopathy, arterial phase, late phase. This is the MRI, late gadolinium enhancement, and I will wait for it to go back again. So we have a septal, anteroseptal, late gadolinium enhancement here, late gadolinium enhancement here, and we can see it also enhanced over there. The advantage is that because we have also the arterial phase in CT, we have a tracking also of the hypoperfused area, which is something that it's not really part of the vocabulary of MRI in general. This is another example, more recent. You see that the protocol here is much better, is much more optimized for the CT. This is a 4D spectral. This is a 40 keV image. So it's really completely enhanced to the level where you see the best of the iodine possible that you can see. And we have the Cine visualization. So we see the late gadolinium enhancement over here, and more static over here on the color-coded map. And this is the MR of the same patient, and this is the echo of the septal, the basal septal wall with the thickening. And in this case, spectral imaging helps us also to see when there is a delayed perfusion. So when we have a stenosis, we can use it in order to see that there is actually a delayed perfusion, even without doing a dynamic perfusion. But we can see the signal that there is a delayed perfusion. And that is a signal that tells us that that stenosis is already at rest, determining a problem. This is the angio, and this is the cross-sectional image of the stenosis. This is a very small occlusion of a marginal branch, basically, that you see here and here, and you see it also here on top, and you see the perfusion defect here. Well, perfusion defect, it might not be correct. It's a perfusion delay, and this is already evident at rest. So you exactly know here it is, and here it is the defect in the arterial phase that you can enhance because you can play with the kilovolts and having the best contrast possible whenever you want. This is another example, the Cine arterial iodine image, Cine venous or equilibrium phase, and you see hypoperfusion here in the arterial phase and delayed enhancement over here in the venous phase. You see it both here and here. This is the optimized protocol. This is what we do now with the spectral delayed enhancement Of course, there is not only the heart, but there is the lung around it. And this is how you get pulmonary perfusion basically in every patient you want. It's very easy. This is a dual phase. If you look at it carefully, you will see that this is a pure pulmonary phase on the left, and this is the immediate phase that is thereafter, so the aortic phase. And you have the differences in perfusion tell you, for instance, in chronic pulmonary embolism or pulmonary hypertension, different diseases. So the last part is just to show you some examples of more complex structural problems. This is a Epstein anomaly. You clearly see here the very low insertion and dysplasia of the tricuspid valve over here, and a comparison with MRI. This is 1.5 Tesla MRI. Look how good is the visualization of the uh, trabecular myocardium all throughout the right ventricle. This is a aortic valve graft. You see how it works. You perfectly can measure the thickening of the leaflets. You can see how they co-opt or not, and there is no problem with that. Also, another kind of metal structure, and also here you perfectly can assess function, thickening, the formation of thrombus, and this is an example exactly of that. So this is a valve with a halt. So there is disease at the insertion of the leaflets of the prosthetic valve that is very easy to measure, very easy to spot, and no problem at all. As a last, very short chapter, I want to show you what we are doing right now with spectral coronary imaging, which is something very new. Nobody could do it. Now we can do it because we have a high resolution that can also be reconstructed in a spectral way. So we can look at the coronaries with different KV while still preserving the high resolution on one side, and also having a pure lumen, which means I take out all the calcifications from the lumen, or just a calcium. So I can perform basically a reconstruction of the coronary like it is a high resolution calcium score throughout the lumen, or a iodine map. And this is an example because you can see here there is a stent in the proximal LAD over here and over here. Very good visualization of the lumen. And if I use the iodine, I take out basically the stent. The stent comes off. I don't have the stent anymore. I will go directly to that. Here, you see it. Okay, here we are. And on your left, you have an image in which there is a lumen and just iodine. Okay, so there is no stent. I can take out the stent. And as I take out the stent, I can take out the calcification, or I can just leave in the calcifications. I can do whatever I want. So, in conclusion, photon counting will change, in my view, the entire world of diagnostic imaging at every level, not only cardiac, everything. Diagnostic questions, which include the word coronary anatomy, will have to go directly to photon counting. And all the things that photon counting will collect, whatever is left, will be done in other ways. But the most part, the ECV, delayed enhancement, the acute myocarditis, everything will go through photon counting. With this resolution, we have the possibility of phenotyping and characterizing atherosclerosis at the time zero, but also along new generation anti-atherosclerotic therapies, which are very costly, and we need to be sure that these therapies are working properly. And mm, plaque assessment will become, because of photon counting, also quantitative, because in order to do what I just said, we need to have tools to do it also not only just looking at the plaque, but we need to quantify, and this is developing, is not far away from clinical practice. And also spectral imaging will take over several specific tasks of cardiac MRI. And I'm very happy to be here and to have given this presentation, and I hope you liked it. And thank you for the attention.
Excellent talk, Dr. Cadematiri. I do have a question, and probably I'll take some questions from the audience. The first one is, as you know, people tend to misplace the words as to what is the standard, the gold standard. We use gold standard very oftenly, very loosely. So people say cath is the gold standard for coronary atherosclerosis, for coronary stenosis. We know that this will change the game. But how about what is around the coronary lesions? We know there is a fat attenuation index, and I would like to hear your experience. What have you seen something different within the fat, perilesional fat?
I don't think conventional methods for pericoronary fat are working properly because there is a great influence of several different parameters, like lumen attenuation is one of the big ones, but also several different others, like the size of the patient, the kilovolts, the milliamperes, the heart rate. And I must say that in several cases, we noticed, because of the photon counting, that there are patients in which there is fluid in the pericardial cavity, in the pericardial cavity, that sometimes is coming through the aortic wall, and it goes into the proximal part of the right and left coronary arteries. And sometimes we call this atherosclerosis, sometimes we call this hypodensity, and that we never saw before. We never saw before, because now we can really look at what it is and understand that, is there a plaque, is there water, is there something else. So, and I think we are in a very early phase, as you said. Gold standard, reference standard. Now it's not a good way to put it, in my view, clinically for the patient, because you get more information from a CT as compared to from a coronary angiogram anyway. And all the treatment is going to be based on CT data, not on angio data. Angio data will be important, but when you find very specific interventional issues and mm, uh, niches of applications.
Great. And do you foresee the creation or use of different contrast media as the traditional iodine?
I think so. I think all companies and probably new companies are working on that, because the fact that we can have a very high resolution, spatial resolution, and a very high spectral, so contrast resolution, in terms of material decomposition, will allow to use different contrast material. So if we can target, and we can basically, different cells or different tissues, like inflammation cells or fibroblasts, or different with different metals, because it's about which metal you can use, like gadolinium or bismuth or manganese. There are several under study, and then they will come to clinical practice, and this will open the gate of molecular imaging with CT.
Great. ¿Alguna pregunta del público? Sí, Doctor José María Hernández has a question for you.
Professor Filippo, thank you very much for your conference. The images that you showed to us are amazing. As I know, the indication for computed tomography for stent coronary are has an indication 3. With this kind of technology, the indication in the guidelines will become to indication 1 is the first question. And the second one is if this technology is this photon computed tomography will improve the measure of coronary flow reserve or is not good for that calculation.
So these are two very good questions. The first one concerning the class of indication. Honestly, I think that as soon as you install a photon counting scanner in any place and you realize that you can perform perfectly follow-up of stents, yes, it may take some time before it comes from class 3 to class 1 in the guidelines, but we will do it anyway. So in clinical practice, uh, when you study a patient with stents, you are not only studying stents, you're studying the rest of the atherosclerosis of the patient, and that is by definition a high-risk patient who is in secondary prevention. So it will take time. I have seen the new European Society of Cardiology guidelines for chronic coronary syndrome last week. And honestly, I'm a little bit disappointed because there is so much evidence for CT right now, even in other fields, not on stents, that stents will follow anyway. But it is still a bit conservative, the approach that is seen in the guidelines, in my view. Concerning the second question, for sure, there will be a massive improvement in the capability of measuring flow on coronary arteries because of photon counting. So calcification will not be a problem anymore for the estimation of flow, and also stents will not be a problem. The problems will be all at the level of automated segmentation and trying to make it as automated as possible. So the tool will improve for sure.
Okay, thank you. Thank you very much for your answer.
¿Alguna otra pregunta de la audiencia? Okay, Filippo, so I just have to say that if this was an opera, I would be crying right now. So I appreciate the time, and thank you again for your time. We know it's very valuable, and you have very little of it. But thank you for sharing your knowledge, and hope to see you soon again.
Me too. Thank you very much for the
Thank you.
opportunity. It
All
was
right.
nice.
Muchas gracias. Con esto hemos terminado este módulo. Gracias a todos.
Gracias, doctor. Muchas gracias. Definitivamente este tipo de imagen va a cambiar la forma como hacemos diagnóstico. De hecho, como un punto interesante, la portada de la revista, el corazón de la portada de la revista es una imagen que se sacó de esta nueva técnica y creo que justamente como el punto de innovación de lo que queremos hacer como Hard Monterrey, es mostrar este tipo de cosas que van a cambiar el futuro y ya son parte del presente en este momento. Muy bien, ahora vamos a pasar con la siguiente sesión, que es un taller de rehabilitación cardiopulmonar, para lo cual quiero invitar a pasar aquí al doctor Jorge Lara, quien va a ser el coordinador de este taller. Ya hubo un pequeño cambio en el programa, inicialmente estábamos considerando a un atleta que se llama José Carlos Herrera. Sin embargo, tuvo ahí un contratiempo, no pudo llegar. Y vamos a ofrecer otro atleta, la experiencia con otro atleta de alto rendimiento, que ahorita va a presentar el doctor Jorge Lara. Eh, Perfecto, estamos ahorita ya preparando todo aquí tras bambalinas para poder traerles a ustedes el taller en el auditorio Hart.